here?
Actually, I really enjoyed taking this class.
Really?
Yeah, it's probably the best class on TH for so far.
Really?
Yeah, a lot of the other ones are kind of like unorganized all over the place. Or the most organized before. So
It's good to hear. I thought. All right. Welcome back, everyone. Let's go ahead and get started. Hello. Okay. So, welcome. Wanted to thank you all for joining us in person today. My name is Amir Ali. I'm going to be one of your course coordinators for this course. Just to make sure you're in the right course. So, PHRD 608, Oncology, Immunology, Therapeutics. Anyone in the wrong course? I think last year we had like a P1 that was freaking out in the back, trying to figure out which course it was. So, all right, before we begin, who had a nice, relaxing winter break? Who had one? Did anything fun? Vacations? You can't do that? You can do it. You can still make time. You can still make time. Who went anywhere fun? Where'd you go? Paris and Switzerland. How long? 8 days? See, some people had fun, all right? Who else? Who else had fun? Who got sick? Yeah, look at that. You are not alone. I still have a lingering cough. This is from 2 weeks ago. So if you're sitting over here, you're in the splash zone, everyone over here. I'm just kidding. I also have like a little bit of brain fog, not COVID related. So if I start going on random tangents, please bear with me here. So wanted to really thank you all for joining us. Can everyone in the back hear me okay? Okay? All right. Good, good. So if we can keep the conversations for after class, please. So we have an exciting year for you all, or a semester for you all, diving into a topic that I'm sure many of you are either dreading or excited about. There's often no in between. So oncology and immunology. So has anyone heard anything specific about this course from last year or any of your upperclassmen? Anything they want to share? Yes, what you hear? Really? Okay, well, that's good to hear. Not that I'm surprised, it's good to hear. Anyone else? Yes. You heard it's easy. Okay. That's not. Okay, she hasn't heard that. Okay, good, good. Okay. So, well, it's not good because I was about to start off by saying this is a very challenging course. So, I think that, here, let me tell you this. The material, I think, is very challenging. And, Dr. Leshkar and I actually took over this course last year, and we certainly made a lot of changes to the course. And one of the major changes we made to the course was really simplifying the material and giving you the material that you need to know to practice as a competent clinical pharmacist in any practice setting. And so that was the big change that we made last year. And I don't know if that made it easier for some students or not. But I think we designed the course in a way that really conveys the information that you need to know in a cohesive manner. And if that makes it easier, that's fine. I don't know. Everyone has their own opinions. I've had some students share with me that it's also very challenging as well. So a couple changes that we've made this year for you all. So we certainly value the feedback that we get. So one of the changes that we made, we're continuously working on revising our content for the course. Also, in the past, we used to have midterms on the same days as lecture days, right? So you'd come in for the lecture, and then you'll have the midterm right after that. The lecture wouldn't be on the midterm. But one of the changes, we heard your feedback, and we actually moved the midterm dates to different dates, right? So hopefully that's a big improvement this year. And so again, we value all your feedback, especially the constructive ones. So that's one of the changes that we made this year, okay? So this first lecture is just essentially going to be an introduction to the course. It's kind of like the syllabus lecture, a little bit background about immunology and oncology. This is not going to be tested, so I want you to really just focus on the material and kind of sit back. You don't need to take copious notes for this, just so that we're all on the same page for this course, okay? I did not post these slides online. I mean, you can watch the recordings after class if you need to reference the slides later on. So a little bit about myself and the rest of the coordinators as well, and our wonderful TAs. So we have a whole team working on this course for you. So it's certainly not an easy feat to put together this therapeutics course. So a lot of help from multiple people. So Dr. Aleshkar and I will be your course coordinators for this therapeutics module. A little bit about me. So I went to UCSF for pharmacy school, so didn't go to USC. So you'll have to catch me up on all the newest fun USC drama. And then I went to PGY1 at Kaiser Permanente in Orange County, PGY2 at USC Norris, and then I stayed on after that. My current role is actually in the cancer center, so right across the street there. Some of you already probably have rotated there. Did anyone get their API rotations yet? When does that come out? Apparently this Friday? Okay. Did anyone rank me as a preceptor? Okay. You might be regretting it later. We'll have a moment of silence for those who get paired with me. No, I'm just kidding. Maybe. So my position there is the hematology oncology clinical pharmacist. So, I work in bone marrow transplantation and CAR T cellular therapies. So that's my focus is over there. So I see patients in the clinic. I don't work in a pharmacy at all. I see patients in the clinic. I see them on my schedule and take care of these patients in different settings. I'm also the PGY2 residency coordinator. You can see my disclosures listed on the slide as well, but that will not conflict with this course in any way. Dr. Aleshkar, would you like to introduce yourself?
Hi, good morning, everyone. So my name is Huda Aleshkar. I'm associate professor here in the clinical department in the School of Pharmacy. I have a lab on the 6th floor, so if you're interested in research, please feel free to come and visit and see what we do. I got my pharmacy degree back in Syria from University of Aleppo, and then I did my doctorate of pharmacy from Ohio Northern, and then went on to, I worked as a pharmacist also for quite a good number of years in community pharmacy. Then I decided to do research, and I went to do my PhD at Ohio State and fellowship at the University of Chicago, and joined USC here back in 2015. I established my research program. I've interacted with some of you in the last few years, whether it was last year in the pharmacogenetic course. I taught some of you, those who attended. You've probably seen me. And I'm happy to interact with you more this course. And those who are interested in research, particularly in leukemia or cancer research or genomics, reach out. We're happy to have a conversation and see how we can accommodate your interest and see where we can guide you during your career. Thank you, and nice to meet all of you.
Thank you, Dr. Aleshkar. Definitely one of my mentors as well, so it's a pleasure coordinating this course with you. So All right. What else do we have? Okay. Now we're going to dive into the hard stuff. All right. So I want you all to raise your hand if you know someone personally that has dealt with cancer. It's pretty much everyone in this room, right? So cancer does not discriminate. Age, gender, race, anyone can be affected by cancer. And I just wanted to convey to you, really the power of this course. So again, I took this course at UCSF, and really the course, the way we are designing it now, is very, very similar to how I took it at UCSF. And in fact, when I took this course there, I really did not enjoy it. I did not like oncology. And it wasn't until I started my rotations and had some patient interactions where I started falling in love with the field and started to dedicate my entire career towards that field. So I'll share with you two stories, and the result of me taking this course, how it impacted two patients specifically just during my API rotations, right? So first, I was an API student in Northern California. So I had a rotation in a primary care clinic, right? So I was a pharmacist. I would be going to the room with the physician, seeing the patients, and then counseling the patients on different things after, whether it's medication, lifestyle adjustments, what have you. So we had a patient that came in, about a 50-year-old female at the time, who had a lump in her breast, right? And so the physician asked her to get a mammogram. She said, hey, she's not sure about it. Like, her friends always say it's not, the best thing to get. It doesn't really help too much. And, life happens, so why worry about it? And so, I was in the room while that conversation was happening, and the physician just kind of brushed it off and then moved on to the next thing, and the patient wasn't planning on getting the mammogram. But I was in the room, and I remember this course. I took it right before I went to API rotations, just like you. And I started thinking back to the risk factors that I learned about breast cancer in this course. And then I started looking at the patient and looking at her clinical profile. And one by one, she was hitting all of the risk factors for developing breast cancer. So after the physician left, I opened up the conversation with her again. And I talked to her about the value about getting mammograms, and I talked about her risk factors as well. And the importance of early detection of breast cancer makes a huge difference in outcomes. Not that I told her she probably has it, of course, and I'm mentioning this all in lay language. So she agreed. So she got a mammogram, and this was still during my rotation, about a week later, and it showed suspicions of malignancy. She got a biopsy. It turned out to be stage 2 breast cancer. They started her on treatment. We referred her to an oncologist about 2 weeks later, and she's in full remission now. I still keep in touch with this patient. This was about 8 years ago, right? So that's just one story. The other story, welcome, come on in. The other story has to do with my uncle. So you learned about BPH already, okay? So you know about the symptoms of BPH. So he went to his primary care complaining about symptoms of BPH, a lot of urinary issues, right? So without doing many tests, his primary care just put him right away on tamsulosin for treatment of the BPH. So, and this was also during my rotations, but not related to a rotation actually. So my uncle visited from Georgia. So he mentioned it to me in passing. And then I asked him, oh, did you get a PSA at all? Does anyone know what a PSA is? Yeah. It's a tumor marker for prostate cancer. So usually it's good if a patient, especially older male, is having these kinds of symptoms, is to check a PSA. Does anyone know what a normal PSA is? Less than 4. So he did not get a PSA. He started on tamsulosin, noticed mild improvements. And I asked him, hey, did you get a PSA? He says, I don't think so. And I checked his labs, no PSA on there. I told him, hey, might be helpful to get a PSA just to take a look. And so he asked his doctor for a PSA. She put in the order. And then, so normal PSA, we mentioned less than 4. His PSA, 98, right? So he was also diagnosed, but is also doing fine now. So the result of me taking this course, just during my API rotations, probably saved at least 2 patients, 2 people that I care about. So that's the value of this course. You may not be interested in oncology, but it's up to you as pharmacy students to be on the lookout for your patients, for your family members, for your loved ones, because no one else will, okay? So the information that we go through in this course, you might find tedious, might find meticulous or not relevant to you whatsoever, but I guarantee you it can make an impact. So it's important stuff. So I wanted to open up the floor now. This is a safe space. Does anyone have any specific stories they would like to share with us about an experience they've had with cancer, whether it's personal or family related? And if you don't feel comfortable now, that's fine. But if I encourage you, if you're open to speaking about it, please come up to me after class. We can kind of have that discussion later on if you have interest, okay? All right, so let's ask the million-dollar question. So how many of you in this room are interested in going into hematology oncology? Show of hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So let's remember that number, 16. Okay. So we'll ask that question at the end of this course, and we'll see where that number is. We joked last year, watch that number go down. It didn't go down last year, but it did go up. So last year, I asked, it was 8 in the beginning. So I don't know, things are changing. It was 8 in the beginning, and then it was over 100 at the end. So let's see what happens this year. All right. So what can you do in the field of hematology oncology as a pharmacist? So you heard a little bit about our backgrounds already, so you can kind of get a sense of what goes on. But certainly industry, hem-onc is a very lucrative field in industry. And so a lot of positions, whether you're looking for an MSL position, med-info, pharmacology, a lot of focus in industry is on hem-onc. So certainly an important topic for you all here. You can also go into clinical. You can do your PGY1, PGY2, and there's a lot of clinical space for hem-onc pharmacists. So you can work in clinics, as I do. You can work inpatient, outpatient, or in the infusion center. So lots of options there. You can go into research. You can get your PhD, work on publications, work on drug development, what have you. So lots of amazing options here. And lastly, academia, you can go into teaching. So let's get a poll here. So how many of you are interested in industry? Okay, clinical, research, and academia. Okay, so it seems like industry and clinical are somewhat tied, maybe a little bit more clinical, and then research and academia after that. So lots of different things you can do, and some of us here, example, Dr. Eshkar and I, have our feet in a little bit of each thing here. So very versatile career, and I encourage you, if you have interest, come talk to us after class, ask us these questions, shadow us, because certainly there's a lot to learn about the different opportunities in hem-onc. Okay. Okay, what is this number referring to? Any thoughts? Every minute. See, that's good. Last year someone said that's their student loan number. I was like, that's pretty good. Not every minute, close, but not that close. So new cancer cases in the whole year, so 2023, right? So it's 2,000 patient cases per year, new cancer diagnosis, new patients showing up to the oncology office and getting that dreadful news that they're diagnosed with cancer. Has anyone been in a room where that has happened before, where a patient receives that diagnosis? You have? It's dreadful. It is certainly dreadful. You often just see these patients and their facial expressions. They're just in disbelief when they hear the news. And it's a difficult conversation to have. And as a pharmacist, I'm typically in these rooms when these discussions happen. The diagnosis is made, and then I go over treatment options with the patients, different options available to them, counseling. What do they expect? What will happen to them moving forward? Will they lose their hair? These are all important questions that patients are curious about, and certainly tough conversations to have. Okay. All right, cancer incidence and mortality rates. So you can see mortality rates are going down. Anyone know why mortality rates are going down for cancer? Early diagnosis detection. What else? Targeted therapy, so advancements in treatment options. So, we've come a long way in terms of our treatments of patients. Almost every week there's a new treatment option, a new regimen available for patients suffering from cancer, and certainly we're heading in that right direction. We don't have a silver bullet yet to kind of one drug that treats all these cancers. I don't think we ever will. But certainly with the new area of precision medicine, with gene therapy, with cellular therapy, we're certainly moving in the right direction in terms of lowering the mortality risks with these malignancies. You can see a breakdown here of cancer type. So I'm a little blind, so I can't read that. So, you can see, breast cancer and lung cancer are, one of the most common cancers that you can see up here. And you can see kind of the incidence breakdown on this slide. Yes? Well, that's the question we're going to be answering throughout this course. Yeah. So there are malignancies, and it depends on the stage of the malignancy and the risk of the malignancy as well. There are some cancers that you can cure. You can cure metastatic testicular cancer, but you cannot cure metastatic lung cancer, right? So there's differences, and there's different stages. So we'll go through that today as well. But it really depends on the patient, the cancer, their staging, how extensive it is, their response to treatment. But the short answer is yes, you can cure some cancers. There are some that are not curative, though. So we are going to break down every malignancy, almost every malignancy, or just really a summary of the common ones, and answer those questions for you. Okay. Median age of diagnosis is 66. So certainly you can see majority, it's a disease state that happens more commonly with age. And that's not to say younger patients cannot be diagnosed, right? So we, there's almost sometimes like a bimodal effect. So a lot of pediatric patients, pediatric cancers are common, not common, but you can see them a lot. So certainly, median is 66, but you can still see some younger patients developing cancer. And it hits you hard sometimes. So I'll just share with you this. We, as oncology pharmacists and as practitioners working in oncology, we often have to kind of switch on and off in terms of detaching our emotions from our patients sometimes, and that comes with time. So I'll just share with you one quick story before we kind of dive into the different malignancies. So we recently had a 23-year-old female come into clinic. She just finished nursing school from UC Irvine, and she was playing pickleball, which I hear is more common these days, with her friends, and she felt like she was slowly becoming more tired earlier. Just with limited physical exercise, she would start getting tired very quickly. So she went to her primary care. They got some labs. She showed she was very cytopenic, a little bit anemic as well. So they referred her to our clinic. So a 23-year-old female. We did a bone marrow biopsy to kind of get a sense of what's going on. It turned out to be AML, acute myeloid leukemia. So we'll get to a slide coming up soon that shows that the 5-year overall survival, relative survival of AML is about 20-25%. It depends on your risk factors as well and risk scores. So, this is a 23-year-old person that I'm having a conversation with about what treatment regimens that she should get, right? Very tough conversation. I didn't have to use as much lay language with her because she just finished nursing school. She was very excited. She didn't really understand the gravity of the prognosis. She thought she was just going to start working while getting treatment. But, AML is a tough one. You're in the hospital for a very long time, and then you perform a bone marrow transplant for these patients, which I'll talk about. We'll have a lecture on as well. But very, very draining disease course for AML. So this patient, we started her on chemotherapy, just blew right through it. No response whatsoever, right? And I picked a very strong one. I was like, hey, we have two options, a stronger one or a weaker one. You'll get more side effects with the stronger one. Did nothing for her, the strong one. Put her on another treatment, second line. Try to induce her again. No response. Line after line after line after line. 7 lines in. This patient was diagnosed 6 months ago. Yesterday, I had a conversation. She developed an infection from being cytopenic. She's 6 lines in. I had a conversation with her, the rest of the team, and her family about changing her to DNR DNI. She was in the ICU at Norris, hypotensive on 2 pressors. This morning I came in at 6 a.m., found out she passed away. So, yeah, difficult, it was a tough day, but you have to learn to detach yourself sometimes from these difficult patient situations. So tough cases throughout, but certainly you can make a huge impact for these patients. Another patient that just passed away of mine got a wonderful wedding invitation by his daughter, and then went to their wedding recently, and they're all, they're thankful. Patients are thankful for the work that you do. They certainly notice it, right? And the impact that you can make is big. So when we talk about different malignancies, we talk about something called 5-year overall or relative survival. And what that number is referring to is the chances of that patient being alive in that time frame. You can see that 2-year overall survival, 5-year, and you want that number to be as high as possible, right? So, there are certain cancers where the 5-year overall survival is over 90%, which is fantastic to see. And there are some that's around 20%. So you can kind of get a sense of the risk that the patient faces depending on the relative survival. You can see this is just holistically of all the cancers out there, 5-year overall survival, 68%, and you can see it increasing. Just shows you that we're improving here. All right, who knows the difference between hematology and oncology? What's the difference? Yes. Study of blood. Well, they both can be cancer. Solid tumors versus liquid cancer, so blood cancers, right? So that's the main difference between the two, and we kind of break up the field. I think there's going to be a time where we're going to have subspecialties in oncology pharmacy because it's really too much for one pharmacist to know every oncology solid organ cancer and every hematology cancer as well. Oncology solid tumors are more common than hematology. My passion, though, lies in hematology. I think it's more of like the Wild West. You kind of just pick random regimens sometimes, find new literature, you try it. Oncology is a little bit more regimented. You have the NCCN, and you kind of just follow each step at a time. Hematology also, it's the same, but it's a little bit more free and unfortunately less options, but we have more reign to kind of try new things for patients to see what we can do to help. Okay, so now we're going to go through a couple cancers. So we still have some time. So just an overview on a couple malignancies. So how many of you here know someone with breast cancer? Okay. Yeah, so certainly very common malignancy. And you can see the signs and symptoms there, breast cancer screening recommendations. So again, we're going to have whole lectures on these topics. So don't worry about taking notes on this section because we're going to have a much more in-depth lecture on it in the future. But this is just to give you a brief overview of the malignancy. You can see 5-year overall survival, 90%. It wasn't always that high. We've made a lot of advancements in the treatment of breast cancer. We used to do very crazy things for breast cancer in the past. Do like bone marrow transplants actually for patients with breast cancer. We don't do that anymore, but certainly have come a long way with our treatment options for patients with breast cancer, and we've been able to increase these numbers. So does anyone know kind of how staging works in cancer, stage 1 through 4? Yeah. So stage 1, meaning it's more localized malignancy, to stage 4, meaning it's metastatic, where it's essentially the cancer is metastasized to different parts of the body, not just the root area of the malignancy. Like, for example, breast cancer can metastasize to the lungs, to the brain, to the liver, to the bones. So that's what metastatic means, as stage 4. So for the most part, and I say most part for a reason, stage 4 cancer is not curable. So if a patient gets diagnosed with stage 4, and it depends on the malignancy as well, and we'll dive into that, but patients are considered not curable. So you move from something called a curative intent, where you're trying to cure the malignancy, to more of a palliative intent, where you're trying to prolong life and make the patient comfortable. So patients who are diagnosed with stage 4, metastatic, it depends how you approach it for each patient. So if we have a younger, fit, 40-year-old female, we'll try more intensive treatment options. We know we're not going to cure the cancer, but we can prolong the patient's life as long as we can, keep her comfortable. But at the same time, if you have a stage 4 patient that's 85, am I going to give her very intensive chemotherapy? You look at risks and benefits for these patients, quality of life for these patients, and you make a decision. Probably you want to go with something lighter for that patient because you're not able to cure them. So typically, our chemotherapies or our regimens are a little bit more intensive for our curative intent patients, earlier lines of treatment, rather than our stage 4 patients or non-curative patients. Does that make sense? Okay. Prostate cancer. So overall survival, 96.8%. Yes, so you can see the signs and symptoms there, the risk factors, and screening recommendations for prostate cancer. So, again, you can have stage 1 through 4 for this as well. And you'd be surprised. So stage 1, and if their Gleason risk is low and their risk factors are low, your treatment option can be observation or active surveillance for these patients. So you're not necessarily having to treat these patients. You can see that with some lymphomas as well. So it's not until these patients are a little bit more high risk that you start to be a little bit more aggressive with treatment. Not to say that prostate cancer is indolent in any way, but it does grow a little bit slower than other malignancies, and we have a little bit more wiggle room with our treatment options for prostate cancer. All right, so you can see these numbers are really swinging here. So we went from 90% to 22% for lung cancer. So definitely a harder malignancy to treat. Lung cancer is a tough one. So very, very painful malignancy. I mean, imagine breathing from a straw. You're having these giant metastatic lesions in the lung that's really invading the epidural spaces as well, pleural spaces. And you can see, again, signs and symptoms, risk factors as well for these patients and screening recommendations. Lung cancer is actually very unique in terms of our treatment options available. So one, lung cancer has a lot of immunotherapy that we've built into our treatment regimens for these patients. And also the field of precision medicine really started taking hold in lung cancer. So now we're able to target very specific mutations for lung cancer with oral oncolytics, oral drugs, to treat specific mutations in the patient's lung cancer if they have them. So we've certainly gone a long way. This number has been increasing in terms of the overall survival, but still very dismal for most patients. Any questions so far? Okay, leukemia. This is the one that I mentioned to you. There's different types of leukemia, of course. The patient that I mentioned to you has AML, acute myeloid leukemia, which is very, very challenging to treat. And so you can see we don't really know too much about what the risk factors are for leukemia. You can see some of the suggestions listed on this slide. So now we're moving more into the blood cancers. Yes? It's a good question. We're actually going to have a whole lecture on this next week, talking about bone marrow transplantation. So Be the Match, just to give you some insight here, is a donor registry for bone marrow transplantation. So we're going to have a lecture next week that will specifically answer your question about who the best patients are to be your donor, right? So we'll answer that next week. Okay. Any other questions? So yeah, AML, again, very, very tough disease state. And one of the main ways that we can cure AML is by doing a bone marrow transplant, right? And, when I explain this to patients, they think like I'm just transferring someone else's bones to them, and it's not, how that works. But essentially, you're transferring your stem cells, your marrow, to a patient. So you're taking your healthy marrow for an allogeneic stem cell transplant. You're taking your healthy marrow and getting rid of the patient's existing diseased marrow, and you're essentially giving them your marrow instead. And we've gone a long way in that as well. That's actually a form of immunotherapy, right? You're using a power of immune system to kind of fight the cancer as well. So that's really going to lead us to a conversation of why immunology and oncology, this course is tied together, is because in oncology, immunology is used very heavily. So we use the power of our immune system to fight the cancer. And that is, I think, one of the future kind of focuses for emerging therapeutics as well. Oh, by the way, so when I first started in HEMONC, started my residency and everything, I started actually developing nightmares, because you start seeing this all the time. Started developing nightmares that I would get like this malignancy. Because you start seeing it all the time, and you're like, that's your whole life. You're just talking about this cancer, treating this cancer. And then like wake up in a sweat, like, oh my God. But like in my nightmare, I'd be like diagnosed with it, and I'd be like running around trying to figure out what to do. So yeah, that does happen sometimes. I don't know if it's just me, but sometimes. I know. Have I convinced you guys yet? I feel like everyone's really down right now after this lecture. Yeah? Is everyone excited now? Okay. No, okay, it's not all doom and gloom. Maybe I'm going in the wrong direction here. There are certainly good cases as well, okay? I'm trying to think of some, but there are good cases. No, I'm kidding. There are certainly cases where we're able to cure patients and be able to treat their malignancies, and they get on with their lives. We do AML bone marrow transplants. These patients stay in remission. We were recently at Norris in this quad area over here. We had something called a Festival of Life, where we invited patients that have been in remission for years, and they give a speech. And I had like 4 of my patients show up and give these speeches. Some of these patients, like, they've been in remission so long that you don't follow up with them as often, because after a certain period of time, the risk of the cancer reoccurring, relapsing, goes down. So certainly a lot of happy cases as well. So I want to get that point across. I think it's equally as important that there are good cases out there, and you can certainly make a difference for those. It's a joy to see those positive cases, because patients, when you cure their malignancy or you get them into remission, there's nothing else like that. So it's a fantastic feeling. So lymphoma, another blood cancer. So this one's a little bit different. There's different types of lymphoma out there. So two major categories. You have Hodgkin's lymphoma, non-Hodgkin's lymphoma. Hodgkin's lymphoma, that one also is actually bimodal, occurs in pediatrics and adults. That one's actually very curable. You give like intensive regimen, a couple cycles, and usually most patients are cured. Non-Hodgkin's lymphoma, lots of different subtypes. You have more aggressive kinds, and you have more indolent kinds of non-Hodgkin's lymphoma, but lots of different therapies available for these patients. Okay, any questions about those malignancies? All right, we're going to dive again into those, obviously, throughout the lectures. You can see the schedule for this course. So we are 1/3 of the first lecture throughout your 9-week journey here, so we're on our way. So it's going to fly by. Yes?
For lung cancer, you said hopefully you have the lowest 5-year survival rate. I know it's one of the main risk factors for smoking. Outside of like the physical particulate of smoke destroying bronchioles and whatnot, what else from smoking causes cancer?
So whenever you have combustion, right, from a cigarette, that releases a lot of particulates, right, a lot of carcinogens. That's part of it. So it's not really the nicotine that's causing it. It's the combustion and the lack of, the filtering of cigarettes is not that great. But, you'll be surprised. A lot of the patients that we diagnose with lung cancer are non-smokers, right? So again, I'm not going to dive too deep into all of it yet, but we'll have a whole lecture that answers that question. The risk factors will be focusing on that as well.
Is there a similar correlation with vapes?
So not as much research yet with vapes. There's certainly a lot of risks with vapes, but when we're looking at lung cancer, it doesn't seem to be at the same level as typical cigarettes, combustible cigarettes. So it's a little bit different, but we don't have a lot of long-term data for it yet. Yeah. All right, so here's the schedule. So again, the way that we designed this course is by, we're going to start off with the immunology piece, actually. So the first kind of lecture or two is focusing on how your immune system works and some immune-related disease states. So RA, for example, is a topic that you'll be discussing in Module 2. The reason we're doing that is because a lot of our treatments for oncology rely on your deep understanding of how the immune system works. So that's why we find it important to have immunology in the beginning. Then we'll dive into your question for stem cell transplant and cellular therapies. Did you guys learn about CAR-T in another lecture course? Briefly? Okay, so we'll have a whole lecture dedicated on that to go over, what CAR-T is and cellular therapies are and some of the risks associated with those. We have midterm, and then we'll dive into oncology. CAR-T and bone marrow transplant is still part of that, but that's still a lot of immune-related topics. So then we'll talk about the different chemotherapy options. So you have to be drug experts, right? So we'll have a couple lectures that just go through chemotherapy options, what you need to know about the chemotherapy, how do you counsel patients on these chemotherapies. We'll talk about the side effects and management of these adverse effects and how we can mitigate some of them from occurring. Then we'll dive into the malignancies, right? So I'll give you the prostate and breast cancer lecture. We'll have a lung and GI cancer lecture, and then we'll have the hematology lecture, so leukemia, lymphoma, myeloma, all in one lecture. So there's going to be a total of 2 midterms and a final exam. So final exam is not cumulative. So each exam just covers 3 lectures. Is that why it's becoming easier? Is that why people are saying it's easier? Because it's not cumulative? I'm just kidding. We'll keep it the same. All right. So this information can also be found on the syllabus. Want to point something out. Last year, we got a lot of emails from students saying, hey, is this table or this graph can be on the exam? And I don't think it's fair for us to just email back that one person and say no. So unless it's publicly stated that something is not on the exam, just assume it will be on the exam. So lecturers are not going to respond to each email letting you know if one thing or the other is going to be on the exam. Any questions about the schedule? Okay. So pretty straightforward, clean schedule. So here's the points breakdown for the course. So each exam is 25% of your grade, and then the final 25% is deliverables, your quizzes, you're completing 2 in-class quizzes, which will start next week. So during the class, we'll just announce, hey, the quiz is now open, and we'll kind of actually even sometimes work on it together. And you'll have 2 quizzes per class and 1 post-synchronous session quiz. So 2 quizzes in class and 1 quiz that you can take anytime for a week, anytime, and it's open for 6 days until the next class happens. So 3 quizzes pretty much per module, and that we'll have just 1 post-quiz today. We're not going to start the in-class quizzes this week. We'll have 1 post-class quiz today. But those 3 quizzes per lecture, kind of that theme will start next week. So I do want to point out something very important, though. So those in-class quizzes have to be taken in class, so they cannot be taken remotely, right? So we go over these cases. These quizzes are based on cases in class. So you have to be in class to take these quizzes, and that will be monitored, right? So IP address, different things, and if the TAs notice that there are some people that are taking the quiz, not in class, that it's going to have some issues with that. So you must be present in class to take those in-class quizzes. If you miss class, you can still take those post-class quizzes, okay? So you don't have to be present in class to take the post-class quiz. So for that reason, attendance is required for this course. We in the past did not have attendance required, and I'll tell you this, we had one, this was like after COVID also. We had one, before Dr. Eshkar and I took over, we had like 4 people starting to come to class, and then like 2 people on Zoom, so it was just not really conducive of a healthy learning environment. So that's, that change we actually started last year, but I think it worked out well. So, but at the same time, so life can happen, certainly aware of that, and we're understanding of certain situations. So if you do have an excused absence, and you can refer to your student handbook for a list of excused absences, we certainly will accommodate those requests. So we'll maybe dive into that more a little bit later. So here are the course objectives. I'm not going to go through every single point. This is also found in your syllabus. You can refer to it as well. I think I've described it pretty much most of the points already, though. All right, so we can have your teaching assistants join us for a second if you guys want to show up here, introduce yourself. So we're going to have 4 teaching assistants for this course. One of the TAs was not able to join us for class today. So these TAs are really going to be running the show for the course. So we're essentially, each TA is going to be responsible for 2 lectures, right? And their name is going to be listed under each module. So if you have an excused absence for that lecture, or a specific question about the content, like if something's not uploaded or what have you, please reach out to the TA responsible for that lecture. If there's something they're not sure about, they'll let us know, and we'll certainly address it. So, but if it's like a clinical question regarding to the content of a lecture, please email the lecturer directly. They'll probably be the best person to address that. So course questions, upload questions, quiz score questions, please email the TA directly. And so I'll have you guys introduce yourselves.
Hello, everyone. My name is Riley Grosso, and I'm a second-year clinical and experimental therapeutics PhD student in Dr. Wong Behringer's lab for infectious diseases. And yeah.
Hi, everyone. My name is Sunny. I'm also a second-year PhD in pharmaceutical science. I am currently doing a research in Dr. Zhang's lab for immunotherapeutics.
Hi, my name is Dante. I'm also a second year in the CXPT program, same as Riley, and I am in Dr. Louis' lab.
You guys can take a seat. Thank you. All right. Yeah, thank you to our wonderful TAs. They're a huge help, so thank you all for joining us this year. They're actually our same TAs from last year, so they know how everything works. We will have office hours. So right now our office hours are set to after class on Wednesdays, so from 12 to 1. But if you need any additional time or want to schedule a specific time with us, please reach out to Dr. Eshkar and I, and we can set some time with you. Okay, so we are right on time. Any questions about the course, in general, the layout of the course? You guys think, is it pretty straightforward? Yes? Okay. All right, so we're going to take a break. We'll reconvene at 10:05. All right, thank you, everyone.
All right, let's go ahead and start again. Can you hear me in the back very well? Please raise your hand if you can hear me in the back. Excellent. All right, I wanted to start by thanking Dr. Ali for excellent overview of the course, of the different types of cancers, and just kind of give you an idea of what this course is about. What I'm going to try to do here is delve a little bit more into some of the basic concepts that you're going to need to understand to really move on with the different type of malignancies and understand them very well. When we mention something, you need to really know what that means. And we're going to cover a little bit more on the biology, a little bit more on the scientific aspect of that particular process. So before I start here, I just put it again the course learning objectives, and please go ahead and read these and see how they fit in the whole course and as you move along with every lecture. I also put my objectives for this lecture, which is, first, I would like for everyone to be able to, by the end of this class, to define what cancer is in multiple different aspects of cancer and the characteristics of cancers, the hallmark of cancer, discuss the different types of treatments and how they are used, be able to distinguish between conventional and precision therapeutics. And we can discuss resistance and the different types of resistance. And finally, we wanted to highlight a little bit, and I know Dr. Ali has already talked about the role of pharmacists, but you wanted to see where your role fits in the process of treating the patients who are diagnosed with cancer. So I'm not going to really emphasize more on the first slides because I think Dr. Ali had made the message very clear. Cancer is a deadly disease. It's the second cause of death, not just in the US, but also in the world. As you can see, it's only after heart disease. So cardiology module or cardiology course was very important, but we are also coming next year, right? So you have to really put some effort in this course to try to help the patients in terms of improving their life expectancy, but also the quality of their life, right? There are a lot of patients are suffering from cancer, as you can see, almost 2 million, and 600,000 die of cancer every single year. So if you think about it, this is every day there is a 5,000. That's way more than what COVID had, the lives that COVID had taken at the peak of COVID. So this is happening every day currently in the US. So as Dr. Ali had alluded, the median age of diagnosis of cancer is in the 70s. So here you can see this is looking at the risk of developing cancer over the lifetime. And as the title refers, is the cancer is a disease of aging, right? As we grow older, our risk of developing cancer increase. That doesn't mean it doesn't happen at younger age, but the risk of developing cancer increases as we age. Why do you think that is? Sorry, can you speak louder? Say what you think. It's fine. Okay. Excellent. That's exactly the answer. Be confident with it. That's exactly the answer. As we grow older, every cell, we are made of bunch of cells, right? Our body is made of a bunch of cells. And when I talk about cancer, cancer start with one cell, actually. So as these cells proliferate, they develop there's an increased risk of acquiring certain mutations, and this is what actually eventually causes cancer. That's what we are going to talk about. What's cancer? Cancer is not one disease, it's a collection of diseases, but it all start with the same process. It's a defect in the cell proliferation, cell survival, and cell differentiation. So these mechanisms in the cell that control these processes, that keep these cells in check to proliferate certain number of cycles and stop if there is a damage, these are all defected in the cancer cells. And once that happens, this cancer cell start to grow continuously, right? It doesn't stop, doesn't have those mechanisms to stop it. And it causes the malignancies that are seen in the different diseases. So the loss of cell cycle control is the hallmark of cancer. And what's cell cycle? Do you remember from biology what cell cycle, what the phases of cell cycle? G1, what happens in G1? Yeah, the cells prepare itself for going into, so it's kind of like, not mitosis, not yet, synthesis, right? The S phase. What happened in the S phase? Correct. So in G1, there's the pre-S, which is the cells preparing itself to go into the DNA synthesis. In DNA synthesis, the DNA get duplicated, right? We have 2 copies of that DNA. That's what S stands for. Then the cells goes into G2, and G2 comes before M. What happens in M phase? Mitosis. That's when the whole cell divides into 2. So the cells prepare itself in G2 to go into mitosis. This process of cell cycle is controlled by, can you see here, like all these genes, or at the end, this product of this gene is a protein or kinase or cyclins. These cyclins and kinases, CDK1, CDK4, and 6, and these are proteins that control the cell cycle. Basically, it controls that process. If the cell has a damage in certain phase, it might block it from continuing to proliferate. Now, then there's a deregulation in these proteins, either directly or something that control these genes, like some of these P2 or P53 or RB, and there's certain mutations. This whole process is deregulated, right? So now this cell can acquire certain mutation, and then they can go into a continuous proliferation. They don't have the mechanisms to block this cell cycle, right? So again, the cells cancer cells start from a normal cell, start from any normal cell in our body. That's why when we talk about breast cancer, it starts from a normal breast cancer cell initially, right? When we're talking about leukemia, it starts from a normal hematopoietic cells, right? But how did that normal cell become cancer cells? We already said that over the time, they accumulate certain mutations, and certain mutations could cause these cells to transform from being normal cells that have these mechanisms that they control their survival and proliferation to now becoming cancerous cells that have new capacities to proliferate indefinitely and sometimes to which is what we call here as clonal expansion, and then to create these tumor cells, tumor mass, that some cells can even leave that tumor mass, go into the microenvironment, and maybe travel away from the initial start of the tumor to create metastases, to create a tumor in different part of the body, right? So these different features that these cancer cells acquire over time, it's really what associate with the aggressiveness of the, depending on what they acquire, what type of mutation, what surface receptors they overexpress, they give them this capacity to proliferate, to survive, to block differentiation, and to travel and cause metastases. And this is what we talk about, the hallmark of cancers. So now the cancer cells have different characteristics than normal cells. What are some of these characteristics? They're here on the slide. Evading the immune system. That's an emerging hallmark of cancer cells. That's now we are trying to understand this better. But in the last 2 decades, we know that one of the main characteristics of cancer cell, because cancer cell, if the immune system worked properly, they would see the cancer cell, right? And they would target it. The T cells will go attack these cancer cells because they express certain receptors on their surface or certain mutation that they're expressed on their surface that can be seen as being different than normal, right? But the fact that these cells are not recognized by the immune cells, then the cancer cells have figured ways to evade the immune system. And there are a lot of these mechanisms, and that's, you can talk about that in the next set of classes, where you can learn about how you use immune checkpoint inhibitors to kind of block some of these mechanisms that the cancer cells have acquired over time, right? There's other hallmarks. Of course, we talked about the increased proliferation, the evading of the immune or like the suppressive signals. We talk about the being indefinitely growing cells, so these don't stop. They continue to proliferate. There's one important thing, we discussed the metastases, but have you heard of angiogenesis? Do you know what angiogenesis is? Can someone explain it? Correct. And why did the cancer, how did the cancer cells try to leverage the blood vessels around it to develop new ones? Why does it need that? More nutrients to be able, because as it grows, you don't want it the center of the you want the cancer cells don't want the center of the tumor to not reach the nutrients. So they leverage this process called angiogenesis to kind of circulate more blood into that tumor. So this is one of the processes that happen as the cancer develop even further. Of course, we talk about resisting cell death, and there's a lot of processes and upregulation of certain genes, downregulation of other genes that block the what we call apoptosis, which is cell death. There's another, we discussed the immune evasion, but there's another process also that cancer cells acquire over time, is changing their metabolism. And why do they need more? Obviously, they need more nutrients, right? So some cells can't rely on mitochondrial metabolism, some on oxidative phosphorylation, so they can basically try to adapt to different conditions in different settings. If it's at the center of the tumor where it doesn't get enough nutrients, they might start relying on different type of metabolism than other normal cells. So this is, in a way, understanding these mechanisms is very important, because it gives us an idea to develop therapies that goes after these pathways or these mechanisms that the cancer cells is developing, right? So when you're talking about if a cancer cells develop certain requirement of certain metabolism pathways, then if you target that metabolism pathway, you might be able to starve the cancer cells from their nutrients, right? Stem cell, cancer stem cells. What is stem cell? Go for it. Try it. All right. It's a precursor, yeah. Think about it in the setting of when Dr. Ali was talking about stem cell transplant. What is stem cell? Correct, and they can renew themselves also, right? That's the unique thing about stem cells, is not just being able to, they can differentiate to different heterogeneous types of other cells, but they can also renew themselves and maintain that capacity to create that type of a tissue, right? So a hematopoietic stem cell, normal hematopoietic stem cell, will renew itself, will make itself again, but it's also differentiated different types of blood cells that include red blood cells, white blood cells, macrophages, platelets, all different types of cells, right? That all come from the original, which is the stem cell. Similarly, in cancer, there is the concept of cancer stem cell. Cancer stem cell is this is small population of the cancerous cells that are capable of renewing themselves as well as differentiating to other cancer cells, but they are a little bit more differentiated than the original cells. In other words, this cancer stem cells, if you take it out of the patients, put it in mice, let's say, you can actually recreate that model in other system. You can recreate that model. And cancer stem cell can go to another part of the body and create that tumor somewhere else, right? So they're aggressive type of cells. Often chemotherapy eradicates the other cells, the proliferating cells of the cancerous cells, but often very, very few type of therapies that actually target the cancer stem cells. And these are the most important cells to target because often they are the one that are kind of cause the relapse when the patient, few years later, if you don't kill these cells, the cancer is going to come again and the patient's going to relapse because of these cells coming back and proliferating and causing the disease again. Okay, is that clear? All right, another concept is the tumor microenvironment. The cancer is very sneaky, right? It utilizes the normal cells around it. The normal, we talked about angiogenesis as one of the mechanisms. It's utilizing the normal blood vessels to circulate itself, to bring a nutrient to itself. It utilizes other type of cells. It utilizes fibroblasts also to make it this cancer-associated fibroblast. These cells that are kind of supporting for the tumor around it to provide support, to provide cytokines, chemokines that can create inflammatory environment that support this cancer cells to grow. So it's often not just the cancer cells, but the surrounding tissue that are otherwise normal, but they're actually supporting tissues that help this cancer to grow. There's other mechanisms. We discussed the immune invasion. Cancer cells can evade immune system by also upregulating or certain markers or by inducing certain signals that will allow to certain immune cells, we call it like regulatory immune cells or inhibitory immune cells that now target other immune cells that otherwise will come and attack the T cells, right? Or the cancer cells. So for example, regulatory T cells could prevent cytotoxic T cells from attacking the cancer cells. This is an immune evasion mechanism. So you can think of this cancer trying to modify the immune system around it to make it not being seen by the cancer, by the T cells, by the being attacked by the T cells. And similarly, this happened for the innate immunity by the macrophages, modifying the shift between the macrophages between M1 and M2 to support the growth of the cancer cells and not being targeted by the immune cells. Another process is called EMT, or epithelial to mesenchymal transition. This is more relevant to epithelial types of cancer, skin cancer, or any cancer that is originated from epithelial cells. Often in certain condition with certain exposure to certain signals or upregulation of certain genes, these cells can transform to become mesenchymal cells, and with that transition, they acquire certain characteristics that allow them to migrate. Now they can metastasize to other parts of the body and cause the disease to grow somewhere else, right? So mesenchymal characteristics tend to be more aggressive than the epithelial. So the takeaway from this portion of the lecture is cancer is a disease of aging. It's a collection of diseases, not just one, but it's all start with the uncontrolled cell growth. And the cell divide, protect itself from different mechanisms that block it from growth, that cause it to die, and they metastasize. This whole process starts with accumulation of certain somatic mutation. Okay, so think of it: cancer is a disease of aging, but a disease of the genes, is a disease of the genome, right? All right, now we're going to move to a little bit talking about therapeutics or therapy of cancers. So these are the 5 pillars of cancer care. As you can see, surgery has been the very old type of treatment, the oldest type of treatment for cancer, when we knew nothing about cancer, we could just remove the cancer, right? The growth. Radiations also is very old. However, they remain very important part of cancer treatment. Often, as these local type of treatments is very curative, especially if the cancer is localized, is small, it hasn't spread anywhere. Surgery and radiation can be very, very effective. In the middle here, you can see chemotherapy, cytotoxic chemotherapy. And this is where all your study during this course is, you can delve into all the different therapeutics, the different chemotherapeutic agents. You can learn about their side effects and where they're used and how they work, what the mechanism of action. So that is where your expertise can be very helpful to understand and how to guide the patients through their course of treatment with chemotherapy. Chemotherapy has a lot of side effects, as you imagine. It's a long treatment, so there is a lot of effort. Clinical expertise are needed. And in the last 2 decades or so, we started getting more molecular targeted therapy and immunotherapy. So we also have in almost every types of cancer that's going to be covered during the course, there will be a portion of the lecture discussing some of these molecular targeted therapies for that particular cancer and the immunotherapy that are relevant. You can think of treatments or cancer treatment modalities as also being part of a local. We talked about surgery, radiation, and systemic. So if the disease is systemic, you can't treat it with a local therapy, right? If you're talking about AML, this is not relevant. If you're talking about metastasized breast cancer, these local treatments are not relevant. However, if it's localized type of malignancies, then this can be actually very, very curative, and it can be very helpful. Often, even if the disease is localized, chemotherapy and other form of therapy can be effective. Can you think of why we would use it, even if the cancer is localized? A small lump in the breast, or go ahead. Mm-hmm. So often, even with the surgery, removing that small lump, surgeons might not take the whole region, or with that surgery, some cells might actually leave that part and go somewhere else. Then there's also micrometastases even before that surgery, or before we don't see them. It's very hard to detect. They can be in other parts, had already went to other parts of the body. So often chemotherapy or other targeted therapy can be very effective even if the cancer is in early stage, right? Conventional therapy versus precision cancer therapy. Can anybody describe what the difference between a conventional therapy versus precision? What is chemotherapy? What do you think it falls within? Oh, it's right there. Conventional, and why is that? Exact. We're not targeting anything specific. It actually kills normal cells as well. If it kills any dividing cells, right? So sometimes the epithelial cells or endothelial cells, these patients will lose their hair, will have diarrhea. You're going to discuss a lot of these side effects of chemotherapy. So it really does not distinguish. Cancer cells are more sensitive, but it doesn't mean that in a way these are targeted, right? It's gonna kill any dividing cells. It's targeting sometimes is the S phase, the M phase of the cell cycle, so they're not specific. Obviously, surgery and radiation are these basically conventional therapy. When we talk about precision treatments, can anyone think of an example of that, and why is that considered a precision therapy? Go ahead. Yeah, that's correct. And why do you think that is precision? Correct. Often is the expression of PD-1 in that will be a biomarker for the response, right? So often you wouldn't just start these medication randomly. Even if the patients had the same types of cancer, they might not actually respond, and you would know whether they can respond or not. So often with targeted therapy or these precision type of therapy, you have a biomarker that can tell you have a specific target that if the patient has, it's going to tell you whether the patient is going to respond to this treatment or not. That doesn't guarantee that they can respond, but often it's the way you start the treatment. For example, certain mutations in lung cancer, for example, ALK mutations. These patients will respond to certain kinase inhibitors, such as alectinib, right? Patients with AML that they have FLT3 mutations, those patients would respond to midostaurin. These are form of targeted therapy. Some of them are extremely effective. They're curative in CML. For example, the tyrosine kinase inhibitor, there's a series of generation of these inhibitors. They're extremely effective. They cure the patient. Patients live all their life. It's kind of like you can think of it becoming as a chronic disease. It's so effective. But some are just extending the survival of these patients. Good example of it can be either biologics, the example that you mentioned, PD-1, PD-L1 antibodies, those are biologics, monoclonal antibodies. There's a series of these drugs that can be used, but also it can be small molecule inhibitors. We talk about tyrosine kinase inhibitor. These are small molecule inhibitors that are specifically targeting specific kinase that is either amplified or upregulated or mutated in the cancer cells. This is a good example. Have you heard of breast cancer, HER2 positive breast cancer? Okay. How many of you knows about it? Excellent. So breast cancer, there are mainly 3 types, right? The triple negative, HER2 positive, or hormone positive, right? So HER2 positive is characterized by the amplification of the HER2 gene, which is a receptor tyrosine kinase. It's a kinase, so it has an ATP binding site here that you can actually target it with small molecules, and this is a list of small molecules inhibitors that can be used. The ones with FDA, these are approved, they're used in clinic. But you can also, because it's a receptor, you can also target it with monoclonal antibodies, and that is the first one, actually, the trastuzumab or Herceptin. It was the first targeted therapy that was used for HER2 positive breast cancer, and it made a huge, dramatic change in the life of these patients. These patients would die prior to Herceptin in a few months. After Herceptins, a lot of these patients would live years. So we've been talking a lot about mutations, targeted therapy, precision medicine. It's important to distinguish when we discuss the genome between 2 types of genome, the germline and the cancer. We're talking about the cancer in the normal, right? So the cancer cells accumulate certain number of mutations over our lifetime, right? And then become cancerous. But that's not every cell in the body, right? It's only the cancer cells that have these mutations. What do we call those mutations? How they're different than something else in a normal cell that we inherited from our parents. They're benign and malignant. So when it's malignant, when it's the mutation that are these acquired over lifetime, we call it somatic mutation, right? When germline, it's something that we are born with. We inherited from our parents, right? It's on every cell of our body. If you take and to be able to test if you have certain germline mutation, you really don't need to take the tumor, right? You could take any cell of the body. You could take a saliva, you could take a hair, you could take any piece of DNA of any other organ and actually test if that mutation or that variant exists. But the tumor, the somatic mutation in the tumor, you have to really take a biopsy of that particular tumor, right? Why is this relevant? Because both types of variants, whether it's a somatic specific to the tumor or it exists in every cell of our body, it actually matter when we are treating patients with AML, with cancer in general. I'm very focused on AML, but we're treating any patient with any cancer. We really care about both information, and we use this to not only develop treatment, but actually there are current treatments that actually leverage this information. Examples of that, when in the cancer itself, we talked about targeted therapy. This targeted therapy can be against a mutation in the cancer, an amplified gene in the cancer, or against fusion drivers such as the ALK fusion. It can be when immunotherapy, you mentioned the PD-1 and PD-L1. These tend to be more effective for patients who are whose cancer have more mutations in them. Someone asked earlier about why lung cancer develop more in smokers, right? We talked about, in general, any proliferating cells can acquire certain mutations, but in lung cancer, these cells, the smoke, the chemicals in the smoke, so all these other components of the smoking induce certain number of mutations, increase the possibility to develop certain mutations. Bladder cancer is another one. Also, exposures to certain toxins can increase the risk of developing certain mutations. With that type of mutation, lung cancer, bladder cancer accumulate way more mutation than, let's say, AML. AML is actually, in any case of AML, there's probably about 14 mutation in that AML case, in that blood sample that you take from the patients with AML and the cancer cells. If you take a tissue from a lung cancer, there will be like a few hundred types of different mutations. Does it mean that they're all driving the cancer or they're all responsible for the cancer? But just because this cancer tissue has a lot of different mutation, that means they can be seen by the T cells, by the immune cells, better than a cell that does not have, that doesn't look any much different than the normal. You getting the point? More mutations suggest that these cells can look different than the normal. And this is the case for bladder cancer, lung cancer. These are highly mutated cancers that can be targeted by immunotherapy. And this is what we mean by mutational load. More mutations, more response to immunotherapy. Neoantigen prediction, this is what I'm referring to when we have more mutations. Mutations can be presented. Do you know what neoantigen is, actually? Let me ask that question first. So it's neo, yeah, exactly. That's how it's a antigen. The immune system see different things as antigens, right? But when it's so when every protein in the body that made by any cell, it's usually degraded in the cell in a process called proteasomal degradation, and it's presented on the cell surface by the MHC molecule, right? MHC, or you're probably familiar with them as HLA. So these HLAs is like complexed with the peptide, with the chopped peptide, and present them on the cell surface. Now, if that protein is coming from a gene that is mutated, it's going to look different than the proteins from a normal cell. And when it's mutated, it's going to be presented as a mutated peptide by this MHC. That complex of the peptide and the MHC is going to be seen by the T cells, okay? And the T cells going to see this mutated complex as neoantigen, right? It's going to be considered neoantigen. It's not similar to the normal, if it recognizes it, that will induce immune response, right? So this is what neoantigen is the presentation of certain peptides by the MHC because they are different, they are mutated, they're not the same as the normal. So this is important because if we know what the neoantigens, we can also develop therapies against these peptides, right? So this is in terms of therapeutic way of thinking about it is very important. Now let's move to the normal. We're talking about all these on the cancer cells, right? On the cancer cells, they have these mutated peptides that are presented. On the cancer cells, they have the somatic mutations, they have these amplified genes, all this on the cancer cells. How is the healthy cells, the normal cells, can be relevant? It wouldn't have. They might, like BRCA1, BRCA2. Yes, they have the first hit. Basically, what you can think of it is if they have a mutation that increase the risk of certain cancer, but they might still need another hit for that cell to become fully cancerous. But also, so once, yeah, you're right, exactly. So, but this is also relevant because if they have that certain hit, like BRCA1 and BRCA2 mutations, first, they give us the information about the risk of an individual to develop cancer, right? Often in breast cancers, if the family member have these mutations, they have higher risk of developing breast cancer. But also, it gives the information about the responsiveness to certain treatment. There's BRCA1, there's PARP inhibitors that I think from those of you, I think I covered this in pharmacogenetic last year. PARP inhibitors are very effective in patients with breast cancer that have, or ovarian cancer that have BRCA1 or BRCA2 mutations. Okay, there is a mechanism of synthetic lethality that makes these cells that have BRCA1 or BRCA2 mutations very sensitive to PARP inhibitors, right? Because it's kind of like this DNA damage repair mechanisms that once you hit one part of it, you try to hit it with the other with the PARP inhibitors, then the cell will go into cell death, okay? But if you have any of these mechanisms still functioning, the cell will survive. So on one hand, having these mutations tells us the risk of the individual, but if an individual develops cancer, then this also could be, in certain cases, actually a biomarker for response to certain treatment, okay? Again, from pharmacogenetics, if you remember from last year, we talked about irinotecan. We talked about certain chemotherapeutic treatments that have high toxicity, but this toxicity can be worse or less depending on pharmacogenetic, depending on certain polymorphisms in certain enzymes, such as metabolizing enzymes, right, for that particular drug. So if an individual have polymorphism in certain CYP2D6, CYP2C9, all these certain that are responsible for metabolizing that particular drug, then the individual, the patient with cancer can be either sensitive or less sensitive to that treatment. So it affects the PK, it affects the PD, it affects the responsiveness, it affects the toxicity as well, right? So germline variants are relevant in this aspect as well. Germline variants also in terms of microsatellite instability, and this concept is similar to the mutational burden. If the individual have microsatellite instability in their genome, in the normal cells, there are hot spots where like these basically area of the genome are less stable, then they are more prone to be sensitive to immunotherapy. This is simple chemotherapy. The definition is drug that stops cell growth. We talked about these are not targeted. They are going to kill any dividing cells. It can be given in different ways. There are different types of chemotherapy. It can be used topically. It can be used injections. But they have, particularly the systemic one, have a huge level of side effects because they are also killing some of the normal cells, right? Chemotherapy can be given in different setting. Primary induction. Can you think of a scenario where primary induction used? You know what primary induction? Primary induction, we can think of it as the only option for these patients. So you're giving chemotherapy because they're not going to be able to be treated with something else. That's the main treatment. And AML, you induce them with chemotherapy, so that's the main treatment. That's primary. They are not going to be able to be treated with surgery or radiation or any other alternative form, right? Metastatic disease, metastatic breast cancers, the primary treatment is going to be primary induction. Neoadjuvant. Do you know what neoadjuvant is? Given before other treatments such as surgery or radiation. And why do you think that would be the case? Make it smaller sometimes, shrinking the tumor, particularly if you want to try to preserve some of the healthy tissues around it, if the tumor is big. It can be also effective to kill some of the cancer cells in the surrounding tissue, right? It's been shown that neoadjuvant chemotherapy extend life, even if the tumor is small, right? It can also give us an important point about neoadjuvant treatment. It gives us the idea if this cancer is responsive to chemotherapy or what type of chemotherapy, because that's your kind of window. Once you remove the tumor, you're not going to be able to get that information, right? So that's also sometimes is important information to know. Adjuvant chemotherapy is given after, right? And can you think of why would you give it after? To prevent it from coming back, because we talked about the micrometastases that could present to any cells that had migrated, that had left that area, so to increase the survival. This is very much what we discussed. So the primary chemotherapy, these are when there's no other options, no alternative treatments. It can be curative in certain types, the primary, particularly in acute lymphoblastic leukemia in children. Chemotherapy, induction chemotherapy can be curative. So back to the question, not all cancers are deadly. So some cancers can be cured with chemotherapy. It's also for advanced diseases, for metastatic diseases, really not the purpose to cure the diseases, just at that point to really relieve the symptoms, to just extend survival and improve some of the quality of life for the individual, right? For a neoadjuvant, here it's to increase survival and basically to shrink the tumors, particularly in cases for head and neck cancer, non-small cell lung cancer, locally advanced, so sometimes you spare the tissues with that, and it increases survival, right? And if it's localized, it can be curative as well. Adjuvant, it's used after, and this has been shown to also reduce the recurrence and overall survival of patients. Again, different types of solid cancers, this is the approach. It can be an adjuvant chemotherapy. Chemotherapies work on different parts of the cell cycle, and some of them are not cell cycle specific. So you can go over these different classes of chemotherapy, and I think module 3 and 4. And you can learn that some of them act on the S phase, for example, these anti-metabolites, they're going to work on S phase. Some of them work on M phase, the taxanes and vincalcaloids. Some more topoisomerases could work either in the G2 or the S. So there are different mechanisms, but some of them might work regardless of where the cell in the cell cycle. Okay, so often you need you treat patients with more than one chemotherapy, and you know why? Why not just give him one? And to prevent the certain mutation from acquiring, that's correct. But also, because these different chemotherapeutic agents are targeting different pathways, now you're really making sure the cells are targeted by different aspects, different mechanisms, right? So often we don't know which one's going to be the most effective, but we know a mixture of one of them. Each one of them work to a certain degree by itself, but with that combination, you could often try to target all the different pathways of survival of these cells, so you block it from going into any other pathways. And of course, these are not done randomly. They're clinical trials that have been done to which chemotherapeutic should be added to each other. It shouldn't be the combination of all the different chemotherapy be very toxic. You cannot use 2 chemotherapeutic agents that can enhance the toxicity. So all this has been studied very well, and it's been tried on in clinical trials to come up with these regimens. Talking about resistance, we try to prevent resistance by combining different chemotherapies. There are 2 types of resistance that we can think of. There are acquired resistance and intrinsic or primary resistance. If you can look at this, can you think of what's acquired versus intrinsic? It's kind of self-explanatory, actually. What's the difference between intrinsic and acquired resistance? Correct. So even before you treat them, if you treat them, they're not going to respond, right? What's acquired? Yes, so they develop certain mutation as they've been exposed. The drug, in a way, the drug had cause them to develop these mutations, right? Over time, there are certain clones, and that's what you see here. These cells here are having intrinsic. They did not die even from the treatment. And these are eventually, once the sensitive cells died, they can cause the tumor to come back again. Versus the acquired ones are these cells that actually, over time, they develop these, they now acquire the mutations after the treatment, and now they're gonna come again and have. Often we see acquired mutations in diseases where the treatment is with receptor tyrosine kinases. So the receptor tyrosine kinase is hitting a pocket where the ATP binds for that kinase, and then the cell will develop a mutation in that binding site. So now the particular small molecule inhibitor doesn't sit there anymore, or even if it doesn't, because of that mutation, the kinase will still be active. So now, because the cell figured a way to protect itself from being targeted by that inhibitor. So these are acquired mutations. Resistance, after we talk about primary resistance or inherent, these resistance in the absence of exposure to the drug, this resistance already exists from the beginning. So in other words, why is this relevant to know if a resistance exists from the beginning? There's no need for it because the patient is not going to be responsive, right? You choose a different therapy that they can be more sensitive to. Example of this, P53 tend to be, these mutated cancer with P53 tend to be resistant to a lot of different types of chemotherapy. Often also this can be resistant to different type of chemotherapy, different type of treatment, not just specific one. So certain resistance can cause the cells to be resistant to multiple ones, not specific targeted to specific drug. The acquired can be often specific to single drug, and this is because the cells were exposed to that particular drug. Now they develop that mutation. And or it could be also to multiple drugs. So, for example, these pumps, the MDR1 gene, which is basically the or transporter glycoproteins. These are on the cell surface. This over time can be upregulated in the cancer cells and make the drug pumps out of the cell. So this can be to any drug, right? So it binds to any drug and pops it out. So the upregulation of or mutation or upregulation of these transporters cause the cells to be resistant to different types of treatment, not just specific drug. Okay. One concept I wanted to cover now, because also it's relevant as you move on in this course, particularly in the lecture of immunotherapy. Have you heard of hot cancer versus cold? A hot tumor versus cold tumor? No? Anybody? Excellent. I'm glad I put that slide last night. Cold tumor and hot tumor is basically just referring to the immune composition in that tumor. So if, and this is in other words, is suggestive of whether that tumor is going to respond to immunotherapy or not. Cold tumor often have very is not responsive to immunotherapy. So there is not much immune cells infiltrated in that tumor, or if there is any, it's often the regulatory T cells, those immunosuppressive T cells. So it's kind of immunosuppressive environment within the tumor. So if you hit it with immunotherapy, often it's not effective. Triple negative breast cancer is considered a cold tumor. It's not very responsive. That tumor does not have enough immune cells infiltrated to be able to be responsive to any form of immunotherapy. While hot tumors, there are a lot of CD8 T cells, these cytotoxic T cells, the immune cells, NK cells are infiltrated there. They are sitting there. They're already ready to be to act once they get the right stimuli. So there's a lot of infiltration of these immune cells, and the presence of these cells within the tumor allow them to, once they hit by an antibody, let's say immune checkpoint inhibitors or any CAR T cell therapy, they kind of already reacting to the immune stimuli, and then they can cause the effect to target the cancer cells. So cold tumors, unfortunately, because of this, the prognosis is worse because this whole option of immunotherapy is not available, but also these cancers tend to be more aggressive. Hot tumor, you can treat them with immunotherapy, and they're more sensitive and their prognosis is better. And a lot of research effort right now is trying to bring these cold tumor to make them hot. So you try to study ways to induce certain signaling to act on these cells to make them more responsive to immunotherapy. This is just simply just covering the different mechanisms of resistance and talk about immune discovering basically the last 2 slides. I'm not going to go through it very much, but it's just simply explaining how cancer become resistant. Heterogeneity is one mechanism. There is other, like inducing, talked about inducing angiogenesis, evasion of the immune response, acquiring certain mutations, and so on. So the takeaway messages from this lecture, from this part of the lecture, is that conventional therapy is basically this treatment that is not recognizing the difference between normal and cancer cells, but they target every replicated cells. Precision therapy, more effective, more specific, and less toxic. It can be small molecule or biologics, and we talked about the different setting where chemotherapy is being used, right? The neoadjuvant, adjuvant, and primary, and the difference between different types of resistance. Where's your role come in place in treating in caring and treating patients with cancer? Very much as Dr. Ali had said at the start, as a diagnosis, when you recognize certain symptoms or patient complain about certain things, you can encourage them to do certain tests, right? So you're helpful here at the appearance of the symptoms, at the treatment. As you can see through the course, these treatments are very extensive, very heavy, has a lot of side effects. There's a lot of managements that can be required. So your role can be very, very important during the treatment and different cycles, but even after that, as the patients survive and live few years. We have a lot of patients living with cancer right now, which is good compared to with much lower survival in the years past. But that require management for these patients over long term. A lot of patients are given oral medications, and this is where we can discuss a lot of these targeted therapy are orally given, dispensed in the pharmacy. You need to counsel this patient and talk to them about the side effects, about what other medication that they can take with, or interactions and so on. So the role of a pharmacist, even if you are not in the setting of hematology oncology, you can be interacting with patients with cancers. You can be interacting with these therapeutic agents, even at a community pharmacy or in your life as a healthcare provider in any setting that you are in. The good news, death is decreasing, as Dr. Ali had shown before. That's great. There's a lot of advances being happening. There are still certain areas that needs a lot of work. There's still certain populations in our community that need extra effort to kind of reach out to them with early diagnosis, early detection. Go ahead. Mm-hmm. I usually ask that question. I did not cover it because I thought Dr. Ali can talk, like we talked about a little bit, but why is that? Yeah, that's a good question. What do you think that is? Can you think of something that we recently became, I think we alluded to that. We have a lot of advancements, that's correct, that happened recently with immunotherapy, targeted therapy. This is kind of follow very much what I show on the pillars, right? And these immunotherapy, targeted therapy started in the 1990s and now we're expanding, and that increased survival. Lung cancer, certain subtypes of lung cancer used to have a survival of very significantly low, like few months. Now these patients living 7 years with ALK inhibitors. That's absolutely right. There's other also factors. Sometimes it's completely unrelated. Early diagnosis, early detection, right? A lot of these technology now are more sensitive, are more effective in being able to detect cancers early. Awareness, smoking, people don't smoke as much, right? That has significantly dropped in recent years. So there's a lot of factors that had caused this drop. Any other questions? All right, so these are, you can read these very much. And I just wanted to leave you with this. This is a very enjoyable book, an enjoyable documentary that you could watch during the course every day, watch a little bit. It can be very inspiring, particularly for those who have already inspiration for hematology oncology. I'll leave it here if you have any question. All right, we'll take maybe 5-10 minutes break. We'll come back at 11:05, right? Thank you.
All right, last hour of the day. You guys can get you out on time. All right. So we're going to get started. And this is, again, the final lecture for the day, focusing on immunology. So very delighted to welcome Dr. Burkhart to give this lecture today. In fact, she used to be the course coordinator for this course, and she certainly laid a great foundation for the course, and Dr. Leshkar and I took over after she went on to do greater things. So thank you, Dr. Burkhart, for joining us today, and I'll leave it up to you to start your lecture.
All right, thank you very much. Can everyone hear me okay? Sort of? Is that any better? A little bit better? No, not at all? Yes? Can't hear anything? All right. Is that better? Yes. All right, excellent. So good morning. I know you've been through 2 hours of lectures, so I'll try and make this as entertaining as possible. By a show of hands, how many people have taken an immunology class before? Excellent. So hopefully this is an easy review for you, and for the rest of you, hopefully this lays a really good foundation for what you're going to be talking about in the rest of this class. So really quick, just to introduce myself, my background is in microbiology and immunology. My research history has been within various facets of the immune system. During my PhD work, I was looking at immune signaling molecules. And then in my first faculty position, I was doing vaccine work for the DoD. Since coming to USC, I've now started looking at stress in the university population. And I teach predominantly within our undergraduate pharmacy program. So I start to funnel students up to come into PharmDs here at USC. Alrighty, so we're going to keep rolling here. Some resources have already been posted on Blackboard for you. Hank Green's crash course, I think, is a very good outline, very quick running tour of the immune system. Goodman and Gilman provide a much more in-depth, which is probably more to your level, but if you're just getting started with immunology, starting with crash course is a good way to get started, start to learn who the players are. And then if you want to know more information, Peter Parham has put together a very, very good textbook. I used it when I learned it as an undergraduate student. I still prescribe it today. They do a really excellent job of updating the edition to stay on top of what's being discovered in the field. So if you are looking for more supplemental information, I really recommend that. And Parham now has the textbook online at a discounted price if you're interested, and you can also borrow it from them as well for an even cheaper price. Okay. So learning objectives, I'm not going to belabor these because these are already in the syllabus. So we're just going to dive right in. So the immune system, why do we need it? Why do we care about it? Why are we spending an hour talking about it today? Well, at its very core, we need our immune system to help prevent infections, right? We've co-evolved with a whole bunch of pathogens that like to use us as an incubator to make more copies of themselves. And so alongside of that, we have our immune system that's there trying to make sure that we don't get overtaken by all of these pathogens. We know now that we have regional immune systems, not just sort of this central immune system. Heard a lot about mucosal immunology. We're starting to see other parts of our immune system mounted places like within our lungs, our guts, our skin, things like that. And because of this, we know a lot of information about how our immune system responds to infections. And if you think about it, there's actually a lot that we're asking the system to do. We have intracellular and extracellular pathogens it has to somehow figure out we're infected with and respond to. And as we'll talk about today, we have our innate and our adaptive immune system that do a really good job of handling this. Another really fantastic thing that our immune system does as a response to these infections is it generates immunological memory. And we've managed to take the fact that our immune system does this and sort of hack it and turn it so now we can create vaccines. So we can provide this prophylactic immunological memory to someone before they even come across that pathogen. Now, we also know that there's some inappropriate responses in our immune system, and I think you've probably learned about these in prior courses. So allergy, that's when our immune system sees something that isn't actually an antigen. It's not a pathogen, but it responds like it is. So that's why if you have seasonal allergies or if you've got a pet allergy, something like that, your body acts like it's being infected, even though it's really not. Autoimmunity is one of the really big inappropriate responses. Instead of our immune system responding to an external pathogen, it starts responding to us. That's a really big problem, right? Because we've got the supply of the antigen it's responding to inside of us. So we have to find some way to stop that therapeutically if we can. We also see an inappropriate response to transplantation. Transplant rejection is completely an immune-mediated activity. That's why we spend a lot of time trying to figure out how well we can match up the immune system between the donor and the receptor to try and cut down on that amount of rejection. And then we also know that the immune system is important in cancer, but similar to a pathogen, cancer has found ways to subvert our immune system, to say, oh, there's nothing to see here, you don't need to respond. Okay? So that's why I put that under an inappropriate response, because our own bodies sort of get in our way in responding to cancer. Now, it's your third hour of lecture. You're probably sitting there going, why the heck do I need to learn any of this? So this is the case I'm going to make to you. There are immunological disorders, some of which we just talked about, that have very druggable targets. If you understand the immune system, you understand where those targets are. We have oncology disorders with very druggable immunological targets. The more we learn about cancer, the more we understand how we can use the immune system to start fighting it. Checkpoint inhibitors, monoclonal antibody therapy, CAR T cells, NK cells, things like that. We have therapeutics that we know about that are based in immunology for autoimmunity and cancer. We have vaccines that are coming out. Was it this week or last week? There was good data that was reported for the breast cancer vaccine. We've got good data on a melanoma vaccine that's coming out. We know that HPV works, the HPV vaccine. That one's a little different because it's infectious disease, but it can still prevent a cancer. And biologics. Biologics are a huge part of the pharmaceutical market right now. And no matter where you go in to be a pharmacist, you're going to come across patients that are going to have something with biologics. It's just too big of a field right now. Recombinant cytokine therapy, monoclonal antibody therapy, antibody drug conjugates, CAR T cells, dendritic cell therapy, CAR NK cells, all of this is based in the immune system. And if you understand the basic immunology behind it, you're going to understand how the patient's going to respond to it, what side effects you're going to see, and how you're going to be able to help them mediate that. Okay? So that's the case that I'm making at the top of my lecture as to why this next hour matters. And if that isn't enough, you can blame this old guy here in the painting as to why you have to be here today. So this is Edward Jenner. He's considered to be the father or the grandfather of immunology, and it's because he designed the world's very, very first smallpox vaccine. He figured out that cowpox, when immunized in the crude way that he did it, is given to someone, it's able to protect someone from smallpox. And even though he did this a very, very, very long time ago, we used his basic understanding that cowpox can protect to actually eradicate smallpox from the world. It was all based on cowpox. So if my pitch as to why being here is important isn't enough, you've got someone else you can blame with this old guy here. Okay, so as I said, the world is filled with pathogens. We are not walking around in a sterile space. We have a lot of different viruses, bacteria, parasites, fungi out there that want to cause disease. And as I said already, this is a big task for our immune system because some of these are intracellular and some of these are extracellular. So not only is there a large range of things that our immune system needs to protect us against, but it also has to figure out how to detect where they are in our body as well. And the other sort of fly in the ointment here is that these pathogens want to continue to use us as a replication factory. We've got good nutrients for them. We're about the right temperature for most of them to come in and replicate. And so they are finding ways to thwart our immune system. So this is a really big task that we've given our immune system to do. Now, a term that I'm going to use a lot, and my guess is in the future you're going to hear a lot in this class, is antigen. So an antigen is a molecule, usually on the surface of one of our pathogens, that's capable of inducing an immune response in the host organism. So even though this is just a little cartoon image behind me, you can see that on this cartoon bacterium, this little greenish, bluish rectangle here is an antigen. This is something that our immune system is going to be able to recognize and respond to. Similar here, this little pink triangle on the virus. So this is used in the context of a natural infection to mount an immune response. But from a therapeutic standpoint, if we understand the cancer antigen or the target on our own cells for autoimmunity that we want to prevent our immune system from responding to, we can start to design immunotherapeutics that will either prevent natural response to these antigens or induce a response to it, usually in the case of cancer. Now, the biggest protection that we have are our barriers. So we have physical barriers that protect us from the outside world. We have these tight junctions within our epithelial cells. Oops. Where did my presentation go? Oops, nope, that's not me. It's not a presentation day unless you have a tech problem. Huda, do you know where in here my presentation is? The whole thing just shut down. It's just the whole thing shut down, yeah. So you all have your slides in front of you, so I'll continue to riff while we bring it back up. So we have these barriers, right, that are able to prevent access, pathogens from being able to access us. And they play a really, really critical role. We have a physical barrier. If you look at that table, you'll see that there's a microbiological protection there. We know now that our microbiota, our natural microbiota, plays a really important role in preventing these pathogenic organisms from taking a foothold. What happens when a patient takes a lot of antibiotics? They have dysbiosis of their microbiota, right? And we tend to see that maybe a bacteria or maybe a fungus can get their foot in there and cause an infection in these people. So these barriers are really, really important. And if we never breached these barriers, we could go home right now. We'd be done. We wouldn't have to talk about our immune system. But the problem is we're human. We cut ourselves, we fall down, we break these barriers open. And because of that, we have to have our immune system in place. All right, so what happens when we breach these barriers? So this is where our immune system comes into play. So I call this the 10,000-foot view of our immune system. And what you can see here is after we have pathogen that comes into our system, it has to reach a certain level that our immune system can recognize it. But once it does, our innate immune system is going to be activated. And as we'll talk about, our innate immune system is going to start responding to that pathogen, make sure we keep a lid on that level of infection, because remember, we have some sort of pathogen that's come in that's going to start replicating, so we have to start dealing with it. And as our innate immune system is responding, our adaptive immune system starts getting turned on, and it isn't until we have both of these branches of our immune system working in concert with each other that we actually start to get resolution of that infection. So it's really important that both our innate and our adaptive immune systems are working together. And at the very end of this, as we already touched on, we'll get the memory phase out of our adaptive immune cells. Our immune system decides, we're probably going to come across this pathogen again. Let's send some of these cells that we used into deep storage so the next time we come across it, we can pull them out even faster. And again, this is what we've hacked or what we've used now to generate vaccines. So let's look at these two branches in a little more detail. We have like I said, our innate immune system. This branch of our immune system is going to respond within minutes to hours of pathogen entering our system. Very, very quick response. And has a very, very non-specific way of recognizing that we have pathogen. It's just looking to see, do we have a virus? Do we have a bacteria? Do we have a fungus? Do we have a parasite? It's not going to ask any more specific questions than that. It's not going to say, well, is this Staph aureus or Staph epididymis? Nope. It's just, is it bacteria, virus, fungus, parasite? And as I said, this really quick activation of this branch of our immune system and this recognition is important because it helps to keep a lid on the level of that pathogen that we have in our system because it's come in and it's starting to replicate. The other thing that our innate immune system does is it tells the adaptive immune system to start getting activated. And this is important because it takes our adaptive immune system days to weeks to become fully activated and to come out and start helping our innate immune system to respond to this infection. And part of the reason our adaptive immune system is so slow to respond is because it is very, very specific in how it recognizes pathogens. It isn't even just going to recognize on an antigen level. It's going to look at individual pieces of those antigens on our pathogens and respond to that. So a much, much higher level of specificity. And the way that we use that to design therapeutics is we can design antibodies, for example, to be used in therapeutic settings that are just going to go after that target. We're not going to see huge off-target effects as long as that antigen that we're going after in the patient is just found in that autoimmune cell or that cancer. Okay? And after we have the resolution of infection, it's the cells of our adaptive immune system that are going to be used to generate that immunological memory. And if you look at this in the schematic on the slide, you can see that the workflow is if we scrape our knee or if we step on a rusty nail, something like that, we've breached our barrier. We have our innate immune cells that are mounted near that site that are going to be able to respond very, very quickly. And then we have these other cells here that are part of our innate immune system but are going to bridge the gap between our innate and our adaptive immune system, come into our closest secondary lymphoid organ, also known as a draining lymph node. If we scraped our knee, it's probably going to be the lymph node that's found in the back of our knee here. And this innate immune cell is going to come in and tell our adaptive immune system, hey, we've got something going on out here. We need you to get activated and come out and start helping us. Okay? So how does this work in a little bit more detail? So in conditions where we don't have pathogen present, we don't need to have a large inflammatory environment. We just are in a watchful waiting stage. But as soon as we breach that barrier, we now have some pathogen that's come in. In this example, it's a bacteria. And our innate immune cells that are found at this site are going to start getting activated. This one's going to start phagocytosing that bacteria, trying to prevent more of it being able to make more copies of itself. And it's also going to start sounding the alarm and causing inflammation. And this inflammation is important because it's going to allow other innate immune cells to come into that site to help cause more destruction of that pathogen that's come in, cause more inflammation of that area. And the other thing that this inflammation is going to do is it starts to signal to our adaptive immune system to start getting activated. Like I said, our adaptive immune cells are going to be residing in our secondary lymphoid organs, so our lymph nodes, our spleen, our tonsils. But they need to be told that something's going on to re-breach that barrier. And so this is where, as I already said, these really important little starfish-looking guys here are able to travel from wherever we breach that barrier, wherever we have pathogen that's come in and we have a lot of inflammation being generated, they come into that closest draining lymph node and tell the cells of our adaptive immune system, you know, I understand it takes you a little bit longer to get woken up and come out and join our party out here, but you need to start working on it now because we're going to need you really soon. I appreciate the laughing at my jokes. And it's really, really important that we have both of these branches of our immune system fully functional. And we've seen from patients that have defects in one or both of these branches how hard it can be to exist in a world where you're constantly surrounded by pathogens. So if you look at the yellow line, this is an individual that has a fully functioning innate and adaptive immune system, and it looks very much like that 10,000-foot view we talked about, right? We have a rise in level of pathogen for a little while, but around the time when our adaptive immune system joins the party, we start to see a decrease, and we're able to resolve that infection. If we look at individuals with the red line, these individuals don't have an innate immune system. Their adaptive immune system is fine, but they don't have that really, really important quick-to-respond branch. And you can see how quickly they lose control of this infection. They're never going to be able to activate their adaptive immune system because without some sort of therapeutic intervention, they're going to succumb to infection first. We look at the flip side of that. With the green line, this individual has an innate immune system, so that quick-to-respond system, but doesn't have that slower to respond but very highly specific adaptive immune system. And they're able to keep a pretty good lid on this infection right up to the point where we need those adaptive immune cells to come out and help resolve the infection. And if you were to look at this timeline for long enough, again, without some sort of therapeutic intervention, this individual would also succumb to infection. So we have to have a balance and a working together of our innate and our adaptive immune systems. Now, like I said, we already talked about draining lymph nodes for things. Our immune system does not just reside in one place. And that's really important, right? Because we're going to come across pathogens a lot of different places, lots of different routes of entry for these pathogens. So we want to make sure that we have parts of our immune system sort of mounted at all of these places where we might come across this pathogen. So in red is where our immune cells develop, bone marrow, and then the thymus, which if you've never learned about the thymus, it's a big gray floppy thing that sort of sits over your heart. And after our immune cells finish their development in these sites, they move out into our secondary immune organs, which are in yellow, lymph nodes here, and then our spleen, which you can see here. And the way that our matured immune cells move around between these secondary immune organs is through the lymphatics, which are like highways connecting all of these secondary lymphoid organs together. So these are both of the branches. Let's figure out who the players are in the immune system a little bit more. So just like all cells, our immune cells arise from a common hematopoietic progenitor. And I'll tell you right now, immunologists are not very clever in our naming scheme. So our lymphocytes come from cells that start with the common lymphoid progenitor. And these should look familiar to you. These give rise to our B cells and our T cells. Our B cells, when they mature, they're also called plasma cells, and they are the ones that secrete our antibodies. If you come down the other side of this chart, these are our myeloid cells. And these are the cells that contribute to our innate immune responses. Collectively, and this depends on the text that you're reading, these will be called leukocytes or white blood cells. But it's the lymphocytes and the myeloid cells all together. And this is not something that I would expect you to know for an exam, although maybe your boards will want to know that at the end of this year, I don't know. But we don't make all of these cells in the same proportion. And if you look at these numbers, it should start to give you an indication as to how important these cells are in our immune system. Why are we going to spend a whole bunch of time and energy making a bunch of neutrophils if they aren't going to fulfill a really important role for us? We must not need eosinophils and basophils all that much, at least in a resting state, if we aren't dedicating all this energy to making them, right? So, get to know a few of these guys a little bit more. So within our innate immune cells, these neutrophils I just talked about, you can think of these as the first responders at like a scene of a crime or at an accident. If you've ever had an infection that caused pus, then you know your neutrophils very well. Pus is what happens when neutrophils die after they've responded. And they are very, very dedicated to phagocytosing, especially bacteria. So the silly little cartoon here where the bacteria is saying, oh no, they've got Joe, is not far off from what they actually do. So in this video here, this is a neutrophil. This tiny little thing here is a bacteria, and these are red blood cells, and you'll see how dedicated this neutrophil is to hunting down this bacteria. So our macrophages are another phagocytic component of our innate immune system. These are much longer lived than our neutrophils. Our neutrophils live about 6 to 8 hours before we have to replace them. Our macrophages are going to live in our tissues for much, much longer, but they're also going to do like what we just saw with our neutrophil. It's going to go and phagocytose things. And then our mast cells, if anyone suffers from seasonal allergies, anaphylactic allergies, you actually know your mast cells very well. We evolved these for protection against parasites, but we've seen, especially in places that don't have as such high parasite burden, they seem to play a much larger role in allergy. And so whenever you start feeling the sneezing, the dripping eyes, it's a result of the mast cells degranulating. I said in that long figure that we have these little starfish-shaped cells that do this really important role of moving from our innate immune cell or innate immune compartment where we've breached that barrier and activating our adaptive immune cells, right? Well, these are actually dendritic cells. And what these guys do is they're out wherever there's antigen that could be picked up, and they'll pick it up and they will migrate, as we saw, into the closest secondary lymphoid organ, usually a lymph node, and they will show that antigen to our adaptive immune cells. And that's how our adaptive immune cells know what they need to respond to. So it's really, really important that these dendritic cells are able to bridge the gap here. And this is really their primary role within our immune system. And they're able to make a lot of contacts, especially with our T cells in these secondary lymphoid organs. In this figure here, this sort of grayish, brownish, I don't know how it's coming across to you, but in the center, this cell here is a dendritic cell. And you can see that it can make multiple contacts with multiple T cells. So they're very, very good at kicking off that activation of our adaptive immune system once they make it into those secondary lymphoid organs. So our B cells, which are some of the main cells of our adaptive immune system, make antibodies. During development, this antibody is actually surface bound to our B cell, but the end result of the activation of our B cells is them secreting these antibodies. These antibodies do a lot of important things for us. They can help to neutralize pathogens. They can help to neutralize toxins. They can actually work with our innate immune cells to cause even more phagocytosis of those pathogens that have come in. And again, because these are cells of our adaptive immune system, there's a really high level of specificity as to how they're recognized. Now, this cartoon is Not exactly what happens with the B cell when it gets activated, but it isn't too far off that we have antibodies that are very, very specific for whatever that pathogen is. The other major cell of our adaptive immune system are our T cells, and these come in a couple different flavors, CD4 or helper T cells, or CD8 cytotoxic T cells. Our CD4 T cells, as their name suggests, they help other cells do things. One of the major things that they do is they help our B cells develop so they can start secreting antibodies. Our CD8 T cells, you can think of these as sort of the ninja assassins of the immune system. They are very, very good at detecting when we have viral or intracellular bacterial infections in cells. And this is really important, right? Because we talked about this idea that we've got extracellular pathogens and intracellular pathogens. How does our immune system know when there's something inside of one of our cells? They don't have some magic scanner that they can go through and say, or knock on the door of a cell and say, do you have a virus inside of you? So it's important that we have these cells that are able to do this for us. And similar to our B cells, because our T cells are part of our adaptive immune system, they have a very high level of specificity for how they recognize antigens. Okay, so we've talked about who the players are, major players in our immune system. We've looked at this 10,000-foot view, sort of this workflow of how an immune response happens. But how do they really develop? So we said we have to kick it off with our innate immune system, right? So we've got a 3-day weekend coming up. Let's say we go to a friend's house for a barbecue. We're walking around barefoot in the backyard. It's warmer than it is out right now. And we step on a rusty nail. So the first thing that we need to do is we need to get our innate immune cells to that site where we stepped on that rusty nail. So there's probably some bacteria, maybe some fungus on that, and we want to start responding to that quickly. So these major innate immune cells are now, we need to get them down to where we've stepped on this rusty nail. So we've now broken our barrier, and we have some innate immune cells there, but we want to bring in as many as possible, right? Why just have the ones that were there to start? Let's bring in a whole bunch. Let's make sure that whatever this pathogen is that's coming through this breach barrier really just can't continue to replicate unchecked. So let's bring in a bunch of our innate immune cell friends. So as we said before, we have these cytokines that are going to be secreted. It's going to help bring in and activate other innate immune cells. And very, very quickly, we have a bunch of these innate immune cells that are responding. We have a bunch of inflammation that's being generated at this site. So while this is happening, remember we said we have these really, really critical dendritic cells. They're going to come in and pick up pieces of whatever this pathogen is that's come in and be able to travel through our lymphatic system to wherever that draining lymph node is. Again, we stepped on this in our foot, so we're probably going to go to the lymph node that's sitting behind our knee. And once that dendritic cell gets there, it really wants to go find a T cell to make out with. It wants to show that T cell that antigen that it picked up and say, hey, look what's out here. We need you to start getting activated. And once those dendritic cells make it to that draining lymph node and make out with those T cells and tell those T cells to get activated, then those T cells, especially those CD4 T cells that we said are helpers, right, are going to then tell the B cells, hey, you need to get activated as well, because we're probably going to need some antibodies for this. So that's the workflow. We have our innate immune cells that get activated wherever we've reached that barrier. Our dendritic cells play that really, really important role of bridging the gap between our innate and our adaptive immune system. And once our dendritic cells tell our T cells to get activated, our CD4 T cells will tell our B cells to start getting activated so they can start the process of making antibodies. Now, unlike our innate immune system, when our T cells and our B cells get activated, they can go through a couple extra rounds of differentiation. They become a little bit more mature than they were just sitting in that draining lymph node. So our B cells, what that means for them is that the antibodies that they make can have different activities. You've heard of IgA, IgM, IgE, these different flavors of antibodies. Well, that causes the antibodies to have different activities. We want to make sure that we have the right antibody for the job depending on what the pathogen is out there, right? So we have these antibodies we're going to generate. They're going to do different things depending on the type of pathogen that we have. Do we need to neutralize the virus? Do we have a bacteria that we want to make sure we're gobbling up even more effectively than the way that our innate immune system's already doing it? And then similar thing with our T cells. We have our CD8 T cells here, as we've already said. These are our ninja assassins that are able to ask a cell, do you have an intracellular pathogen in there? Do you got a virus or a bacteria? Or maybe in the context of this class, do you have cancer going on in there? Is there something happening with our cells that's gone a little strange that we should start responding to? So these CD8 T cells, really, really important for that. And as we already said, at the end of all of this, one of the really, really great things is that after we've resolved our infection, we don't need all that inflammation anymore. We don't need all those adaptive immune cells, but we are going to save a couple of them. We're going to send them to deep freeze. If anyone's ever done tissue culture before, or bacterial culture, you know that you save some for a rainy day just in case something happens. It's the same thing in the immune system. We're probably going to come across this pathogen again. So this whole workflow, because our adaptive immune system is a little slow, takes about 7 to 10 days. That's a while, right? I mean, we've got our innate immune system there, making sure we don't lose control of anything, but that takes a little bit of time. But if we can send some of these adaptive immune cells that take a little while to develop initially to memory, we can complete this whole thing in about 3 to 4 days. So that's why we save some of these cells and send them to the memory compartment. Okay. So like any good relationship, for these immune responses to develop, there has to be good communication. Our immune cells have to be able to talk to each other. If they can't talk to each other, no immune response is going to develop. And we've established this by using knockout mice where they can't talk to each other, or looking at patients where their immune system isn't able to talk with itself. So our immune system needs to know the who, what, where, when, and how. Who's invading? We're going to have to mount a different immune response from the adaptive angle if it's a virus versus if it's a bacteria. What do I need to do? Do I need to start phagocytosing things? Should I start secreting defensins? What do I need to do? Where do I need to go? Oh, okay, so our barrier's been breached. Should I go there now? Or my dendritic cells, should I stay here, or should I start going to that draining lymph node so I can start activating our adaptive immune cells? When do I need to go there? And then how are we all going to work together to destroy this invading pathogen? So there's two main types of communication within our immune system. We have direct communication and indirect communication. So with direct communication, we have a ligand on cell A that's going to bind to a receptor on cell B. And as a result of this, you're going to get some intracellular signaling cascades that are going to happen. And it really depends on which cells you're talking about. Some of these signals may tell the cells to survive. Some of them may tell the cells to proliferate. Some of them may tell the cells to mature, become more differentiated. Some of them may tell the cells to die. Why does this matter for this class? Because these are really great targets. You can start to hit these things with monoclonal antibodies and then have the cells either die or not be able to be activated by their binding partner. With indirect communication, we have a cell that secretes a soluble factor that's going to travel through the lymphatics or through the bloodstream and interact with its cognate receptor on another cell a long distance away. So the great thing about this is it means that our immune system cells don't all have to be next to each other to communicate like they do in direct communication. We can have these long distance conversations. And similar to what happens with this direct communication, when this soluble factor binds to its cognate receptor, you're going to get these internal signaling cascades, and it's going to depend on the context of it and what cells we're talking about. But within these indirect communication, we're talking about cytokines and chemokines. And again, these are representing therapeutic targets for autoimmune disorders and oncology. So we've actually already met our cytokines here in this figure. Remember, we said we have this innate immune cell that gets activated. It starts phagocytosing this bacteria. And one of the things it does is it's going to secrete these cytokines. It's going to help build upon that inflammation in that area, help allow other innate immune cells to come into this environment. Question?
What's the main difference between cytokines?
Give me a couple slides and I will answer that for you. Chemokines, you can think about them as the traffic directors of the immune system. We have all of these cells in our body that have to figure out where they're going to go under what conditions, right? So our chemokines are responsible for doing that. And we know this by looking at the way that different immune compartments are organized. We look around the body, we can see where the ligands for these chemokines are expressed and where the receptors, what cell types their receptors are expressed on. And what happens is when these chemokines are expressed in a gradient, it causes the cells with their cognate receptor to move towards that gradient. So this is how we can start to move immune cells around over long distances within our immune system. How we manage to get these dendritic cells that are out where we've broken that barrier to then move that long, long distance, at least for them, not for us, but a long distance for a little dendritic cell, to move from where we've stepped on that rusty nail to that lymph node that's behind our knee. They're following chemokine gradients to get there. Another reason why chemokines are important for this class is that people much smarter than I have shown that cancer uses this chemokine system to metastasize. Cancer puts specific chemokine receptors on their surface and then follows its cognate ligand that's being expressed someplace else, then metastasize to another part of the body. So if we're able to block this interaction, we're going to be able to shut down metastasis from the original tumor site to these distant tumor sites. So, really quick summary of cytokines versus chemokines. Have I answered your question? Excellent. Okay. We're starting to run a little slow on time here, so I'll let you review that. I've also given you a soup to nuts immune response, basically everything we've just talked about that you can review in your own time. All right. How can we use the immune system therapeutically? AKA, you're probably asking, why do I care about any of this, Dr. Burkhardt? All right, here's my pitch again. The current therapeutic landscape for both autoimmune disease and cancers is shifting to target or enhance patient immune function. So if you understand the immunology behind this, you're going to understand roughly how that therapeutic is at least expected to work and what adverse events you're going to expect to see in the patient. It's going to empower you as clinicians to help your patients better. So, what are we currently using for what we just talked about with our basic understanding of the immune system and how it responds to natural infections for autoimmune diseases and cancers? So, recombinant cytokine therapy, this isn't used so much as a monotherapy, but it's starting to be combined with things like CAR T cells to enhance the activity of the CARs once they get infused back into the patients. Monoclonal antibody therapy absolutely is now starting to be the king of therapeutics, especially for autoimmune disease and for cancers. And cellular-based therapies are coming. You know, CAR T cells were approved by the FDA in 2017, starting to be kind of ancient history, but they're starting to be used a lot more. And they're starting to be used for things outside of cancer. There was a paper that was just published last year where they started using CAR T cell therapy in autoimmunity, and they're starting to eradicate autoimmunity in some patients. This recombinant cytokine therapy takes advantage of that communication that we just talked about, these cytokines that are secreted by our cells that then interact with a receptor on another cell, sometimes a very long distance away. And again, depending on the type of cytokine that we're talking about, because there are quite a few of them, you can have lots of different actions. Now, we don't actually go into a patient and collect the cytokines that they're secreting. We can now make them in the lab using recombinant gene expression technologies. But we can use them to do things like differentiate a patient's cells or help their cells survive better. So has anyone heard of IL-2 therapy? A couple hands. So this is a recombinant cytokine therapy. IL-2 is a cytokine. It's a really, really great survival factor for T cells. If you're ever working with T cells in the lab, make sure you pour some IL-2 in the dish. T cells will basically hop out. They love IL-2. The way that it's used clinically, at low dose, it can be used as an antiviral therapy for Hep C. We've now moved on to better therapies than that, but it is occasionally still used. But at high dose, it can be used at cancer therapy. So it's used in metastatic melanoma cases, metastatic renal cancer, and kidney cancer. Like a lot of anti-cancer therapies, you know, based on the numbers, it doesn't look like it's a fantastic cure. We'd all love it for it to be, 90%, 100% cure. But in about 8% of patients, IL-2, high-dose IL-2 therapy can cause a reduction in tumor size. Again, these haven't been found to be very effective as monotherapy at this point, but they are starting to be incorporated with more of these cellular-based therapies that are being used in the clinic. Where we see recombinant cytokine therapy being used a lot is with interferon therapy, another one of these recombinant cytokines that we can make. There's lots of different types of interferons, and again, it really depends on which one you're talking about and which disease state. There's just a few that I listed here. Interferon beta can be used in autoimmune disease, can be used, interferon alpha can be used as an antiviral therapeutic, and interferon alpha can also be used as an anti-cancer therapeutic. Monoclonal antibody therapy, again, this is huge class, ever-growing class of therapeutics that are relevant for both autoimmune disease and for cancer. They can be used as diagnostics or treatments, and they expand beyond just autoimmune disease and cancer. We've also used them in infectious disease, allergy, and metabolic disorders as well. But for the context of this class, you'll be talking about them for cancer and autoimmune disease. One of the great things we figured out how to do is to conjugate therapeutic agents to the antibody, the FC region. So if you imagine the antibody is doing YMCA, the FC region is where my legs are. So we can start to conjugate drugs there, or we can start to conjugate, radionuclides there. And remember, antibodies are part of our adaptive immune system. They're really, really specific in their response. So we can start to get really specific delivery of these drugs to these patients that can start to cut down on the side effects and the off-target effects that we're seeing in these patients. One thing that you will hear, I'll get up on my soapbox for a second, is people say that monoclonal antibody therapies do not have side effects for the patient. That is absolutely untrue. They just tend to be less than maybe oral chemotherapies, okay? And just to underscore how amazing these therapeutics are, they won the Nobel Prize for Physiology and Medicine in 2018. So this is a really amazing class of therapeutics that's becoming more and more relevant that I am sure all of you are going to see at some point in your career, even if you don't go into oncology. And this is because pharmaceutical companies are betting really, really big on this therapy. If you look at this chart, you can see that the number of monoclonal antibodies that are being included in portfolios just continues to go up. The FDA has now approved over 100 monoclonal antibodies for therapy, and the US is currently the largest market for these, and we're projected to continue to be the largest market. So these are going to be very relevant to your career as pharmacists. There's a lot of advantages to these therapeutics. They've got longer half-lives, they have fewer drug-drug interactions, they can be, as we said, very, very highly specific in what they target. And the nice thing is we can engineer these in the lab to further increase their level of specificity and how tight they're able to bind to their target. There are limits to this therapy, though. It's not a magic bullet, it's not a wonder drug, unfortunately. You've all been in pharmacy school for 3 years, so you all know that every single therapeutic comes with some sort of a side effect, and it's the same thing here for these monoclonal antibodies. One of the biggest things we have to be careful of with monoclonal antibodies is a lot of these are generated in mice. Our immune system will recognize mouse antibodies as foreign and will start to mount an immune response against it. So we have to do what's called humanizing these antibodies to make sure that our immune system doesn't mount a response to the therapeutic. So I've included this handy chart here. I would recommend bookmarking it, keeping it, tucking it away somewhere when you actually have your full lecture on monoclonal antibodies. The way you can tell how humanized an antibody is comes down to the suffix. The more humanized the antibody is, the less the risk of that patient's immune system mounting a response against it. So ideally, we'd like all of our monoclonal antibodies to be humanized. Practically, that's very expensive. Takes a lot of time, so not everybody does it. And you can see some of these FDA-approved monoclonal antibodies, not all of them are fully humanized. They're on the market, they're being used, but something you have to keep an eye out for in that case is at some point, if it isn't fully humanized, the patient's immune system will start to respond to it, and it's no longer going to be an effective therapy. There's lots of ways that we can use monoclonal antibodies in cancer immunotherapy. I'm not your subject matter expert on this, so I'm not going to go into this in great detail. You will have a whole lecture on this, but please, I encourage you to use this as a cheat sheet, sort of a preview of coming attractions on that. But there's lots of different ways that we can use this therapy for cancer. We can also use monoclonal antibodies for autoimmunity. Some of them are listed here. Again, you will have a whole lecture on this. This is just more of a preview of coming attractions, but you can start to familiarize yourself with some of these. We're running a little short on time, so I'm not going to go over that. You guys are going to get RA, right? Yeah, okay. So you have a subject matter expert coming in on RA, so because I'm running short on time, I will let them tell you about that. Cellular therapies. This is another place where we can use the immune system to help patients. Two of the most successful of these are dendritic cell therapy and CAR T cells. Remember, we said our dendritic cells, these are our innate immune cells that connect our innate immune system with our adaptive immune system. They really want to make it to that draining lymph node and go make out with some T cells, right? So we can use that for cancer. And in fact, a company down in Orange County did this for prostate cancer. They took dendritic cells out of patients with prostate cancer in a dish, basically fed them prostate cancer antigens, and then reinfused them back in the patients. And those dendritic cells did their job. They went to the closest draining lymph node, found some T cells, made out with them, got activated, and now we're able to take the patient's immune system, have their T cells start responding to their own cancer. CAR T cells, more and more CAR T cells are starting to be approved. Similar to our dendritic cell therapy, these T cells come out of the patient. In the lab, they take that T cell, they claw the T cell receptor off of it, they engineer that T cell to now express a T cell receptor specific for that patient's cancer. So we've now super weaponized these T cells, right? Because all of those that we infuse back into the patient are just going to be specific for that patient's cancer. We infuse them back in, and the hope is that those CAR T cells are going to go attack that patient's cancer. The first one of these to be approved was for ALL. Now, again, you have a subject matter expert that's going to be coming in on this, but there's a lot of toxicity that can be associated with these CAR T cells because we're sending in weaponized T cells. We're telling them, go attack this cancer. So something that you will probably talk about is cytokine release syndrome. We see a massive inflammatory response to the infusion of these CAR T cells back into patients. There's different ways that it can be managed, but because of this, all CAR T cells are part of a REMS program. One really quick thing here. I said that if you understand the immune system, you can understand the side effects of these therapies for patients with autoimmune disease. A lot of chemotherapeutic regimens cause neutropenia. Remember these cells that we looked at and we said they're going to chase down the bacteria, these neutrophils, these first responders? A lot of chemotherapeutic agents target cells that grow and divide rapidly. Our neutrophils only live about 6 to 8 hours, even if they're not part of an infection. So these are part of the cells that are going to be hit by these chemotherapeutic agents because naturally they divide and grow very rapidly. Because they play such a critical role as our first responder in the immune system, when our patients start to go neutropenic, it can be really problematic because you don't have these first responders that are there. And they're very, very susceptible to infections. Again, if you understand the immune system, you understand how these chemotherapeutics are going to impact the immune system, you can start to get an idea as to what these side effects are going to be and start to plan for them. And in fact, we have auto-injectors that can be given to patients that re-stimulate the replacement of those neutrophils. So they can walk out of the clinic with this mounted on their arm to help combat the fact that their neutrophils are being hit by their chemotherapeutic that they're taking, and hopefully make sure that they aren't going to succumb to infection. All right. That's my pitch. I'm happy to take any questions you have.
All right, there's going to be a post-class quiz that's going to be open until Tuesday, next Tuesday at 11:59. That's when it closes. Yes. It's graded. It's graded. We'll see you next week. Thank you.